Hello everyone, welcome back to my channel. My name is Dr. Tina, and in today's video, guys, I will be teaching my gynae short notes which I have made during my preparation, and I would be reading these notes completely for you guys so that you can use the best from my notes. So let's get started. Okay guys, so first of all, I will be telling you the embryology, and these are the short and concise notes which I have made from Sakshi ma'am's notes, okay, for my preparation at the time of MCI or FMG exam for your last days especially, okay, so that you can revise gynecology in complete 1 hour, which I used to do. So let's get started. And what you have to do is you have to mug up few things here, then only you would be able to revise gynae fast, okay. So first of all, embryology. So basically what you have to learn in gynecology, that the embryology is originated from the mesoderm, okay. We have endo, ecto and mesoderm. So embryology of gynae is from mesoderm, okay. Now you have to learn these could come in form of one liner, okay, from your histopath purpose or basic histopathology. So what you have to learn is endoderm. From endoderm, congenital sinuses form, okay, and from intermediate mesoderm, your urogenital ridge is formed, which forms your gonads and your renal system. All right, and your external genitalia, whether it is a male or female, it is formed from lateral plate mesoderm. Okay, this you have to learn. That's why I have made the sticky notes here. Now basically, see, you have to learn this, okay. When you will practice MCQ or something, you will understood that your ovaries are formed from genital ridge, okay. Your uterus, upper part of vagina, and your fallopian tubes are made from Mullerian duct. See, you just imagine the basic reproductive system of a female, which consists of ovaries, your fallopian tubes, your uterus, and then vagina, right? So what you have to do is, by imagining this, you should know what is originating from what where, okay. So if you have two ovaries, these ovaries are coming from genital ridge. Then you have fallopian tubes, uterus, and the upper part of uterus, vagina, sorry. So it is formed from Mullerian duct, okay. When two Mullerian duct fuses, it forms your uterus, fallopian tubes, and upper part of vagina. Then you have lower part, one third of vagina, that is formed from urogenital sinus, that is from endoderm, okay. This is what you have to learn, and this will help you later on, okay. Now you have to again mug up. This page is for mugging up only, okay. Now genital ridge, which is forming your ovaries, it is formed by fifth week of pregnancy, okay, and till sixth week it is an intermediate. Then you have sex gene, which is present on SRY region of short arm of Y chromosome, okay. If this SRY region is present, then testes will be formed in that embryo, okay. And if this SRY region is absent, which means that this will be a female, ovaries will be formed, okay. Then you need to learn this, that testes are formed when seventh week, and ovaries are formed on eighth week, okay. And these are the genes which are responsible, that is SOX9 for testes and WNT4 is for ovaries. All right. Okay, now this remnants. You need to learn this. In males, we have two remnants, and in female, we have three remnants. And these are prostatic uticles in male, appendix of testes in males. Then female, we have mesonephric ducts, which is your Gartner ducts. Then you have mesonephros, which forms your cranial and caudal part of paraoophoron and epoophron. When you will see the image, then you can easily remember. Just Google it, okay? Then you have this ducts, mesonephric and paramesonephric, which appears on ninth week and disappears on appears on sixth week and disappears on ninth week. Then you have Sertoli cells. See, the Sertoli cells you all know present in males, right? So what these Sertoli cells will do, they will start forming a Mullerian inhibiting factor by the seventh week. Okay. So these Mullerian inhibiting will be Mullerian duct. So the name of This factor is Mullerian inhibiting factors because it is going to inhibit the Mullerian duct, and you know that the Mullerian duct forms your uterus, right? So if Mullerian inhibition will be there, so no uterus will be formed, so it will be a male child. Okay, then you have Leydig cells. Leydig cells form produces testosterone, we all know, right? By the eighth week. So these testosterone will promote Wolffian duct, right? So Wolffian ducts are for males. What you have to learn, see, Mullerian duct and Wolffian duct. Wolffian ducts are, you learn it like this, the males are wolf. So they will be coming from Wolffian ducts, and females are soft, or we can say Mulayam, so they are coming from Mullerian duct, like this. And Sertoli cells are inhibiting Mullerian duct, so male is embryo is male, and if Leydig cells are producing testosterone, those will promote Wolffian duct. See, we have Mullerian and Wolffian duct both, right? One has to regress and other has to promote, then only a male or a female child will be born. Simple. So if Mullerian inhibition is occurring, so promotion should also be there. So Wolffian duct promotion will be there, so that male child will be forming. Vice versa, right? Then your testosterone, which are coming from Leydig cells, they will form dihydrotestosterone, and your external genitalia will be formed of male. Simple. So because of testosterone, you are having external male genitalia. Then your Wolffian duct will form your internal male genitalia. See, you have external and internal. External will be formed from the testosterone, which are producing by Leydig cells, and your internal male genitalia, which is your seminal vesicle, your epididymis, your ejaculatory duct, vas deferens, these are formed by Wolffian duct. Okay, you can remember it in this form: seed, SEED. One is ejaculatory duct, one is epididymis, then you have seminal vesicles and vas deferences. Okay, and this is small chart of homologous organs, means the same embryological origin. Okay, so male have prostate, which produces fluid, and female has kidney gland or paraurethral gland. Those, their function is also producing fluid. Then you have Cooper gland or bulbourethral gland in males. The similar to this in females is Bartholin's glands. Just learn them by heart. Okay, Litter's gland are present on penis. Okay, so and the glands of labia majora are similar to Litter glands in male. Then you have gubernaculum, and in female you have round ligament. Okay, now male and female again. See, penis, both penis and clitoris are homologous, and they are originating from genital tubercle. Okay, genital tubercle is giving rise to penis and clitoris in female. Then you have a basic genital swelling. So if a child gets exposure to testosterone, these genital swelling will form a scrotum, and if not, then labia majora. Then you have genital folds. These genital folds will form penile urethral part, and in female they will form labia minora. Okay, this is how you have to learn. There is basic swelling, genital tubercle, and genital folds. If testosterone will be there, they will form penis, scrotum, or penile urethra. If not, they will form clitoris, your labia majora and minora. Okay. Okay, now you have congenital adrenal hyperplasia. It is a condition when there is excessive exposure to testosterone. Okay, so if there will be more testosterone, what will be happening? In this condition, we would be calling it a congenital adrenal hyperplasia. Later on, we will discuss it about more. What you have to remember here is, see, there is what happens. There is deficiency of 21 beta hydroxylase enzyme. Okay, and if this enzyme is absent, there will be increased level of androgens, progesterones. Okay, and excessive androgens will come ambiguous genitalia. Okay, and which means that you cannot differentiate whether it is a male or a female child by looking at the external genitals. Okay, so what will happen? You will having more progesterone. There will be more salt water deficiency because mineral corticosteroids are not forming. Okay, And so basically what you have to do is, for screening of this condition, you will check 17 hydroxyprogesterone levels. Okay, if these levels are less than 300, then you have to do nothing. But if these levels are more than 800, it confirms that there is deficiency of this enzyme and the condition is congenital adrenal hyperplasia. But if the levels are between 300 to 800, in between, then you have to do a diagnostic test. Okay, and if it is more than 800, then it is a confirmatory. Okay, for diagnostic, what you would be doing, ATCH stimulation test you would be doing after half an hour. If 17 hydroxyprogesterone levels are more than 1500, then you can say it is a condition of congenital adrenal hyperplasia. Okay, and the treatment of choice in this condition is fluorotic cortisone or hydrocortisone. That's it for this paper. Moving next, now we are studying menstrual cycle. That is the base and the most important topic which everyone has problem with. Okay, mostly boys have always complained that they don't like gynae, they are reading it. I am getting messages also from so many of you that you are having problem in gynae, reading gynae. So this is the ultimate and the best and the simple thing which I did. So listen carefully, guys. Okay, if you have to learn menstrual cycle, just make this easy, that menstrual cycle is based on two hormones, that is your estrogen and progesterone. Okay, we have two halves of cycle. How we calculate these two halves of cycle is that there is menses, then the ovulation and menses. Between these two, ovulation and menses, you have 2 days, two phases. Okay, a follicular phase, that means when first you are having menstruation is starting, your endometrium is shedding down. From that day till the day of ovulation, okay, that is cause your follicular phase, because all the endometrium has come out. Now again new endometrium has to form. So it will start proliferating, folliculating, because follicles will form. So it is a follicular phase and a proliferative phase. So in these days of in this phase, estrogen will be a dominating hormone. Okay, so this proliferation will be happening in these days. Then ovulation will occur, and then after ovulation till again menses, these 14 days is called luteal phase, because corpus luteum is there. This is a fixed duration phase, and it is also called a secretory phase, because in this phase the endometrium will be become juicy and thick and juicy. And in first half of cycle is proliferating, it is multiplying. Okay, like this is the basic idea of menstrual cycle. Okay, so the menses of from 1 to 28 day, which is common. Okay, and you, if you have to count the day of ovulation, that when the ovulation has occurred, you have to count 14 days backward. Okay, if a child says that, or female child says that today I am menstruating, so you can count 14 days backward to check the date of ovulation. Okay, and this is a fixed, that's why it is called a fixed duration, because you can count 14 days backward to know your ovulation day. Okay, and here it is corpus luteum is max at 22 day. Okay, max in size. Okay, now some of you would be asking what is corpus luteum, if someone doesn't know by now also. So corpus luteum is the left out follicle from where the ovulation has occurred. Okay, that is called corpus luteum, and it produces your progesterone. Okay, so by 22nd day, it is maximum in size, and for these 14 days it will be producing progesterone to maintain your endometrium, to support it and making it secretory and juicy endometrium. Okay, now this is the basic ideology. Now see these small charts. Okay, see, first we have estrogen surge, then we have LH surge. Okay, this everyone knows. Okay, before LS surge, 14 to 24 hours before LS surge, estrogen surge will be there, and after estrogen surge, you can say 14 to 24 hours, then LH surge will be there. If this surge wouldn't be there, then no ovulation will occur. That cycle will be called anovulatory, that ovulation hasn't occurred. Got it? Which means that to ovulate, okay, to ovulate you must have LH surge. Okay, this surge is needed. If this peak of hormone would not go, then ovulation will not occur and that cycle will be anovulatory. Okay, so for ovulation, for basic idea also for men and women, to any female, ovulation requires hormones peak. Okay, surge is needed. So this alert surge is needed for ovulation. Okay, so when your follicular phase, when your ovary has follicles and these follicles are producing estrogen to promote your uterus, these estrogens will be increased. Okay, this estrogen surge is there. This surge means that estrogens are reaching to their peak. Okay, and that estrogen will go to FSH and will say that stop producing FSH and start producing LH, sorry, luteinizing hormone. And then your luteinizing hormone will start forming, and slowly after 14 to 24 hours of estrogen surge, and LH surge will be increasing because they have got the feedback, and that surge will cause ovulation after 10 to 12 hours of surge. Okay, that's the basic idea of your follicular phase to cause an ovulation. Okay, once your ovulation is done on the 14th day or 16th day, whatever is the day of ovulation, now after ovulation, corpus luteum is max at 22 day, right? So the corpus luteum produces your progesterone, as I told you earlier. So now your peak of estrogen progesterone will be there by on 22 day. Okay, now you have peak of progesterone, your hormones are your progesterone hormone is there, your endometrium will be very secretory, juicy, thick and supported by this progesterone. Okay, now your progesterone will be start going down slowly as corpus luteum size will start also decreasing. Okay, this is max at 22. Now it will start decreasing in size. Your hormone level will also go down, and when it goes down slowly, then your menstruation occur. Okay, as I told you, LH surge will cause ovulation for your endometrium to shut down also. This uh, this is needed. Okay, so when these progesterone levels will go down, you will start having menstruation by the 20th day or 30th day, whatever is the cycle. This is the basic ideology you need to know, and this is what menstruation is for everybody. All right. Now these are few questions which you must know. These are like one-liner question which you must read. Now what is there? Ovarian cycle initiated by FSH hormones, right? These are follicle stimulating hormone which are produced from your pituitary gland. What will happen? These follicle stimulating glands will come and stimulate your follicles in the ovary to produce estrogens. And when these estrogens will be formed, then estrogen surge will occur, and this estrogen will go to uh, FSH and say you stop releasing, and ask pituitary to release luteinizing hormone. Then luteinizing hormone will start forming and the surge will occur and ovulation will happen. This is the basic ideology. Now what is the size of follicle just before ovulation, right? So the follicle which will be in 18 to 20th in size, which is the maximum size, then that follicle will be ovulating. Okay, now LH surge to occur estrogen, how much is needed is 200 Okay, now LH surge happens after LH surge. When will ovulation occur? After 32 to 36 hours, or you can say 24 to 36 hours. Okay, it's from surge. And if we talk about the peak, LH peak to ovulation is 10 to 12 hours. Okay, now this is about corpus luteum. Few things that which the luteinizing hormone, your corpus luteum, it is present in a female patient which is which is not pregnant. Okay. And the HCG is it is also produced by your your corpus luteum, but in female which are pregnant. Okay. Lifespan of corpus luteum in non-pregnant female is 10 to 12 days. After that, progestin will also be decreasing because the size of corpus luteum is decreased and menstruation will occur. But in a pregnant female, what happens? This corpus luteum doesn't utilize, right? So it stays for 10 to 12 weeks instead of 10 to 12 days, and this will form progesterone and your HCG hormone, which is important for the baby, for the embryo. Okay. And from these 10 to 12 weeks, after this 10 to 12 weeks, your placenta will be formed, so that there will be corpus luteum to placenta transfer will be there, that now placenta will be producing this HCG hormone for the embryo, and this corpus luteum will utilize. This is the basic thing. Okay. HCG protects corpus luteum from utilize, because HCG is producing during in pregnant females. That's why this corpus luteum doesn't utilize within 10 to 12 days, other than they are staying for 10 to 12 weeks. That's the concept. Okay. Now, time between estrogens and LH peak, 10 to 24 hours, as you saw in the chart also. Then LH surge initiated by, estrogens, right? LH surge requires both estrogen and progesterones. Okay, some amount of progesterone is also producing, but more estrogens. Before ovulation, LH and FSH surge required. Ovulation is because of LH surge only, but no estrogen, nothing, because estrogen surge is causing LH surge. Okay, because it is giving feedback to FSH and asking pituitary to release LH more. So your estrogen surge is causing LH surge, but LH surge causing ovulation. Cool. Okay. Now this is also a question. Meiosis 1 is resumed by LH surge. MCQ. Okay, now this is a basic three charts which you must remember, and you can also see the images, and you have to learn the differentiation. What is a Gardner cyst? It is present on your anterior lateral wall of vagina inside. Okay, and that will be tiny, tender and shiny. When you will see the image, it will be tender and shiny image will be there. There will be no rugosities, because the vagina has rugosities, right? That would be non-reducing, because it won't be reducible, and by cuffing that impulse will not be present. Okay, and the wall will have a defined margins. If we talk about cystocele, that is from comes from vagina only, that won't be shiny, rugosity will be present, that would be reducible because it is coming from inside the vagina. Okay, cuff impulse will be present, and no well defined margins you can see. And if you talk about Bartholin's cyst, it is present between the labia majora and minora. Okay, in between these two labias. Okay, that is your Bartholin's cyst. You must know the basic difference. You never know what they will ask in exam, and you will be feeling like, what they ask this. So this happens every time in exam, that you don't know, and they will ask something easy or stupid, you can say, and you would be like, there were thousands of important topics and they're asking this. So this will happen, so prepare for this as well. Okay, now this is few condition where you need to learn that when your LHFSs go down. Okay, now I know this is difficult to remember, feels like, but you can learn basic things. Okay, like PQS, this is a mnemonic, and then, okay, you can even leave it, because what happens, you read it, but during exam you again forget, so there's no point. Again, now menstrual cycle, I told you, now that was the basic idea. Now we will be reading about menstrual cycle. Okay, your primary oocyte is always initially hormone independent. Okay, then meiosis diplotin will occur at puberty, hana. Then secondary oocyte with polar body. When your follicle will ovulate, your secondary oocyte will be released, plus a polar body. First polar body releases. Okay, and at that time hypothalamus pituitary ovarian axis will be functional. Before it wasn't. When it will be functional, then this primary oocyte and first polar body will be released. Got it? Few mnemonic, few one liners that when is the follicles maximum? When by the uh, fifth month in pregnancy, the max number of follicles will be present in embryo. Okay, that is 6 to 7 millions, and by the time of birth they left only 1 million, and by from birth till puberty it will remain only 4 to 5 lakhs of follicles in the ovary. Okay, now when your hypothalamus and pituitary ovarian axis is functional, what will happen? The granulosa cell which are present in your ovaries, they will start producing follicle stimulating cells, because with those follicles those follicles which are 4 to 5 lakh present in your ovaries, what will happen? These follicles will get stimulated by follicle stimulating hormone. Okay, and these follicle stimulating hormone will stimulate your follicles to produce estrogens, and these estrogens will form when they will reach at a level, they will give negative feedback to FSH that now you stop producing, your work is done, and give positive feedback to LH, which is luteinizing hormone, and ask uh, pituitary to release luteinizing hormone, so giving positive feedback to LH. Okay, and they will third what they will do, estrogens, they will proliferate your your uterine endometrium. Okay, proliferation will occur, and they will also produce inhibin B. This is an MCQ, that they produces inhibin B also, granulosa cell. This inhibin B will help in releasing more LH and down regulating the FSH. This is the basic thing. Okay. Now you see you have a ovary. Ovary has a cortex area and medulla area, right? This cortex had granulosa cell at the corners. You can say, which are producing your FSH, follicle stimulating hormone. Then in center you have medulla, which has theca cells, and these theca cells are producing luteinizing hormone. Easy. Got it? Now you have these questions. FSH receptor present on where? See, your granular cells are causing follicle stimulating hormone to stimulate your follicles, right? So these are present on your cortex, which has granulosa cell. Now granulosa cells tumor of ovary are called feminizing tumor. Okay, tumor marker for tumor of granulosa. If any female has a tumor of granulosa cells in the ovary, then what would be a tumor marker? See, it is producing LHFSH, you know, but what you need is inhibin B is specific. So that's why I'm saying inhibin B is important, because it is a marker of tumor marker for granulosa cell tumor. Okay. Now what happens? Your LH, which is increasing, produced by theca cells, they will, what these theca cells will do is they will produce more androgens. Okay, these androgens are releasing from granulosa cell. These will work on granulosa cell, and these androgens will be converted into estrogens. This is the basic menstrual cycle. That let's re-revise again. Simply, your follicle stimulating cell hormone is stimulating your follicles, which are producing estrogens. How they're producing estrogens? That these estrogens, follicle stimulating hormones, these are causing estrogen surge, then they are causing LH surge. This LH surge, what it is doing, this LH has theca, this is acting on theca cells which are producing androgens. These androgens are going transferring from theca cells to granulosa cells, and these granulosa cells are converting androgens into estrogens. Okay, and these estrogens are doing their function. LH also doing is meiosis 1 is resuming because of luteinizing hormone, and ovulation is occur. Okay, because primary oocyte is converting into secondary oocyte, and this secondary oocyte is called corpus luteum when ovulation occurs. Okay, this is your corpus luteum. Now this is a term that middle shimmer syndrome. What is it? You can learn it as a pain in mid cycle due to ovulation. Whenever ovulation is occur, pain is occurring in a female. This is called your middle shimmer syndrome. Okay. Now, corpus luteum, if we talk about corpus luteum, which is now we have to talk about the second half of the menses, right? Your corpus luteum. See, when you will listen to me, you will understand, you will imagine this everything. Then, whenever the question will come, you will understand, okay, this is what, where it comes from, and what it is doing. This is what you need to know in menstrual cycle. Okay, now corpus luteum, you know, it is a left out portion of secondary oocyte, right, from which ovulation has occurred. The egg is released with with first polar body. Okay, now what this left out corpus luteum will do is they will produce progesterone. Okay, what this progesterone will do is it will give negative feedback to LH that now your work has done, you start decreasing. Okay, so LH is decreasing. It will, what it will do, it will again decreasing progesterone. Support of myometrium will be sorry, endometrium will be lost. Okay, listen to me again. Corpus luteum is producing your progesterone to make your endometrium supportive and juicy. Got it? Now this progesterone will also give negative feedback to luteinizing hormone only to stop producing. Okay, when this luteinizing hormone will stop producing, again the progesterone only is going to go down, right? So progesterone will be decreases. When the progesterone will be decreasing, as I told you, the hormone has to go down, then only the menstruation will occur. And this is the concept of OCPs also, that you are giving hormones only in your oral contraceptive pills. When these hormones are continuously given by that pills, your hormones are in your at their levels. When you stop taking your tablets OCPs, your hormones goes down and the menstruation occurs. That's why people takes OCPs. Okay, so now progesterone are also decreasing. When the progesterone levels are decreasing, now it will cause what, your endometrium to shut down because the support has lost now. Okay, and the metalloproteinase is the enzyme which causes your endometrium to shut down when your progesterone levels are lost. One thing. Okay, now come again here. Corpus luteum's function we are talking about. It produces progesterones. What it is doing, this is what. Now second, they are doing, they're supporting the uterine endometrium. Then third, they are also releasing estrogens and inhibin A. Learn again, your inhibin B is produced by granulosa cell and your inhibin A is produced by corpus luteum. Okay. Now this estrogen and inhibin A will give negative feedback to FSH. Okay. Come again here. When your luteinizing hormone goes down, progesterone support lost, endometrium starts shedding, menstruation occur. Number one. Number two, the vasoconstriction will occur. Okay, what this vasoconstriction will do, prostaglandin F2 alpha will act and causing contractions, and this is called painful menstruation. Okay, dysmenorrhea, or you can learn it as dysmenorrhea. That's how I remember it, dysmenorrhea. Okay, so these contractions which are because of prostaglandin F2 alpha F2, learn it because of that. See, endometrium is shedding because of low levels of progesterone, but the pain and the contractions are because of prostaglandin F alpha 2. Okay, number 3 is your estrogens and inhibin A, which are also decreasing now. If estrogens will go down, you know, again FSH will start producing. That is your follicle stimulating hormone, because these will go and produce ask follicles to stimulate and produce estrogens. Because estrogens levels are going down, what will happen, your deep layer will proliferate because estrogens are start to produce. Then these granulosa cell will form estrogens and they will make it more they will proliferate it more. It's a cycle. Okay, now as we were talking about corpus luteum, this is from day 14 to day 28 is all about corpus luteum. At day 22 you have max size of corpus luteum. So 14 to day 22 the corpus luteum will increase in size, and from day 22 to 28 or 30 till the menstruation start, your corpus luteum will decrease in size. This is what you need to learn. Okay, and your corpus luteum will produce progesterone, estrogen, and inhibin A, and you learn their function here. Got it? Simple about the menstrual cycle. Now we will talk about the condition. See, you learn about menstrual cycle. What is dysmenorrhea? Is dysmenorrhea, pain at menstruation. Okay, now see, if a female patient comes with the complaint of pain during menstruation, okay, so what you have to think about, there could be two conditions, that primary dysmenorrhea or secondary dysmenorrhea. These has to be on your fingertips. That primary means that the patient has pain during first days of periods, and in secondary dysmenorrhea the patient has pain even after third, fourth, fifth, seventh day till the periods end. Okay, now you know the pain is due to prostaglandin F2 alpha, right? In primary cases, because initially to menstruation to occur and contraction will be there, so these prostaglandins will be working. So the pain is because of these things, as we learned in the previous paper. Okay, and that pain will be spasmodic, and these will be occur on your initial few days, 1 to 2 days maximum. Okay, and these will never present after 2 to 3 days. Okay, and the treatment for this condition is NSAID, or you can give mefenamic acids. Okay, and if we talk about secondary dysmenorrhea, that the pain persists, then this could be due to any pathology, pelvic pathology basically, right? It could be endometriosis, adenomyosis, fibroids, polyps, it could be anything. So, and the patient will says that it is not spasmodic, the pain stays, it is a continuous pain, and it stays for 7 to 5 days till the menstrual cycle. Then then you can ask the patient to get your ultrasound done. Okay, we have to find out the pathology. So basically first you need to differentiate between the primary and secondary amenorrhea, then you can think of the treatment and condition, right? So that's the basic concept, that you must know what is primary and secondary, right? Now this is few characteristics of menstrual cycle, the number of days normally. Okay, you just read them by yourself. Now we talk about atypical uterine bleeding. Okay, this is very common. When you will understand these menstrual cycle, guys, then you will be able to answer gynae MCQs very easily, because in your paper 2, when your gynecology, surgery, all these types of lengthy questions will come, you need to read them carefully and understand. So when your concept will be clear now, basic concept, then you will very easily find out your answer. Because okay, so atypical, what is atypical uterine bleeding? That the pattern of bleeding is vary. Okay, now what is menorrhagia? The term menorrhagia means is bleeding, excessive bleeding. Meno means bleeding, rhagia means excessive, so excessive bleeding. Now these are small you can say definition type, that if the levels are more than 85 ml bleeding, then you can say this is menorrhagia. To every female who is menstruating does not have menorrhagia, excessive bleeding, right? So if the blood which has come out is more than 85 ml, or the periods are staying for more than 7 days, then you can say this is a patient with menorrhagia, right? Now what is hypomenorrhagia? Hypo means we everybody knows less, right? So reduced bleeding, you can say less than 5 ml blood is coming, okay, or less than 2 days the menstruation is occurring. This is called hypomenorrhagia. Okay, and mostly this type of condition we see is in Asherman syndrome. And if I have to ask what is Asherman syndrome, some of you will answer in a minute and some will think what is it. So basically Asherman syndrome is when the adhesions between the uterus is formed, that is called Asherman syndrome. And why it is caused? Yes, that is because of when excessive dilatation and curettage is done. So in some cases these adhesions are formed because of that, right? Okay, now oligomenorrhea and polymenorrhea. Oligo means also we think always about like well, less. No, oligomenorrhea means less number of short cycles are there, sorry, long cycles that are there, less number of bleeding is there. So oligomenorrhea is very less blood is coming in very late time. Okay, so long cycles, 30-day, 40-day, 50-day long cycles. That's why these are called oligomenorrhea. And you have polymenorrhea is very short cycles, means after every 15-20 days bleeding is happening. So poly means more, you can say. So after 15 days again and again bleeding is coming. So that's why poly. And oligomenorrhea means long cycles. Why? Because after months, after 2 months, after 50 days cycle is coming. So that's why oligo, very less cycles. Now you have metrorrhagia. Metrorrhagia means, I have learned it like this: the metro, it stops at every station, na? So it is intermittent bleeding. So stops and then occur. So metrorrhagia is intermittent bleeding, irregular bleeding, right? And this can be seen in case of polyps or fibroid. Then you have menometrorrhagia, means excessive bleeding which is irregular. It could be it is occurring anytime, irregular, very irregular, which is mostly seen in fibroid or polyps, right? Okay, now if a patient, see, now you understood the menstrual cycle, you understood that there is pain in menstrual cycle, right, which is called dysmenorrhea, and which is because of prostaglandin F2 alpha, right? And you also understood there are two types of dysmenorrhea: primary and secondary. Primary from starting, and secondary is till last also. Okay, now you need to know, if a patient comes now, because when they are asking question in exam, they are not asking like one liner or something. They will give you a case scenario. So you must understand how you're going to think for that question. So patient comes with complaint of excessive bleeding. Okay, now you understood excessive bleeding. Okay, that excessive bleeding, is it painful or non-painful? Okay, so this is how you will think. So excessive bleeding, it could be atypical uterine bleeding, which I have told you here, or dysfunctional uterine bleeding. One two thing, you will ask that to get a transvaginal scan done, okay, to check the endometrial thickening. Because if a patient coming with excessive bleeding, okay, now we are not talking about the virgin females, right, or a young female, we are talking about the females which are sexually active. On those only we can do transvaginal scan, right? So patient comes to you of middle age, like 30, 35, or 28, let's say, and she complains of excessive bleeding. The first investigation what you will be getting is transvaginal scan. And then in that transvaginal scan you see endometrial thickening. Okay, now you need to learn these charts. In this way you will figuring out question answers during your exam also. That if a patient comes with excessive bleeding, you ask her to get a TVS done, and in that TVS you saw endometrial thickening. Okay, thickening is there, so no problem, all right. Now you would be seeing that female is menopausal or premenopausal, right? So if the female is menopausal, let's say, so her, see, if you know that a menopausal female is not ovulate, sorry, not bleeding is not occurring, she is not having menstruation, then 100% there is uterine atrophy, which means that the endometrium will be very thin. So the size of endometrial thickening should be less than 5 mm or less than 4 mm. Okay, if it is more than 5 mm, 4 mm on transvaginal scan, then you must get a biopsy done. Okay, so in this case scenario, a female of 55 years of age comes to you with excessive bleeding complaint, and you ask her to get your TVS done, and on that TVS you saw endometrial thickening. So you would be thinking she is a menopausal female and she has endometrial thickening more than 5 mm or 4 mm. You need to get a biopsy done to rule out any cancer or something, right? So biopsy is done, and on that biopsy you saw what? Localized thickening, that one localized area is has a thickening. So you will get an hysteroscopy and a biopsy done for that focal thickening. If you see there is uniform thickening of entire endometrium, then what you would be doing is endometrial aspiration biopsy you would be getting. Okay, once that biopsy is done, it is an first of all, it is a OPD procedure, okay, and the instrument which we use for this is Pipile device and Vibra aspirator. This is an MCQ which has been asked. They have shown image also, so you must know for biopsy, endometrial aspirational biopsy, you need a aspirator, that is Vibra aspirator, and a Pipile device for it. Okay, again, if the female which comes to you with complaint of excessive bleeding, she's a premenopausal female, okay, menopause not has not occurred, so the size of her uh, endometrium should be less than 12 mm. If it is more than 12 mm, then it is a doubtful condition and you must get a biopsy done. And again, if that biopsy is so thickened uniform, then go for endometrial aspiration biopsy. If it is focal localized, then go for a hysteroscopy and biopsy. That is the your plan for treatment. Okay, now move forward. That was atypical bleeding. If dysfunctional uterine bleeding is there, there would be three conditions. First is menopausal female came to you with this complaint, then you have to rule out cancer always. If a reproductive female comes and then a young female at puberty come with menorrhagia, that she is very young, recently she has started menorrhagia, excessive her puberty hits and she started menstruating, but she complains of excessive bleeding or menorrhagia. Okay, and here also these two things, that for a young female always it is contraindicated do a per vaginal examination and dilatation and curettage. Okay, you must know these. Okay, now the treatment for dysfunctional uterine bleeding. First of all, you won't do anything. Patient come with excessive bleeding, you will give them first line of treatment, that is your metal spas. Okay, mefenamic acid, stanamic acid. Secondary, you can give OCPs. If the pain doesn't resolve by that, you can give OCPs, or progesterone is always the best. Okay, but one thing what you have to do is, a patient complains of excessive bleeding. First, you think you need to check her vitals. If her vitals are stable, her blood pressure is stable, then you have to give her nothing. But if her vitals are severe, okay, that they are unstable, do dilatation and curettage to stop the bleeding, and then give IV estrogen for the, to proliferate the endometrium again. And if her vitals are stable, then give her estrogen or OCPs, okay, oral contraceptive uh, pills, just to balance the hormone. Okay, that's the concept. If a female is over 40 years, then also bleeding is not controllable, she's complaining of excessive bleeding, the always best is to go for hysterectomy. You will see for so many MCQs the question would be about this only, that what should you do. So the answer should always be that if a female is in her late 40s or early 40s and her family is completed, she has fibroids, she complains of excessive bleeding due to any reason, it is always best to get hysterectomy done. Once her uterus would be removed, there would be no risk of any cancer in future or excessive bleeding which will cause her other problems, anemia, okay, all these. So it is always best to get a hysterectomy done. In so many conditions, the treatment of choice is hysterectomy. You will get to know that later. Okay, because these type of question only will come in your exam, right? Now you're done with menstruation. There are types of different bleeding patterns. Now you have syndromes. Now you need to learn what is Kallman syndrome. See guys, basically याद बस ऐसे रखना है that it is X-linked, because Kallman syndrome is about females, right? So in female, so it is X-linked. This is how you have to remember it. Okay, and why this syndrome is happening? Because there is a mutation in Kallman gene. Easy peasy. Good. Now what happens? See, you have gonadotropin releasing hormone which is releasing from your hypothalamus. Okay, so it's releasing from the arcuate nucleus of hypothalamus. Okay, in pulsatile manner, and it is a decapeptide. Okay, basic about this. Now what happens? The neurons which synthesize your gonadotropin releasing hormone, they are present in olfactory palate, right? And from there they transport via olfactory nerve and reaching to arcuate nucleus. Okay, from where this is going to release, they are forming there, but they are reaching to arcuate nucleus, and from there they are releasing in pulsatile manner. This neural migration is absent in the patient who has the mutation of this Kalman gene. So that's why this syndrome occur, and the gonadotropin releasing hormone is not releasing, and the patient will come to you with complaint of amenorrhea. Okay, this is the basic pathophysiology in simple words. Now what happens? See, guys, this migration will be absent, so for sure this hormone is not going to release from the hypothalamus. So hypothalamus failure will be there, and it is coming via olfactory nerve or olfactory pallid. So this will be absent. So anosmia will be also absent. The patient complains of anosmia also, and somewhat of color blindness. Okay, now gonadotropin releasing hormone is not releasing from your hypothalamus because of this condition. So LSH, FSH are not going to release for sure. These will be down. If they won't be there, estrogen will also be less. So patient will come to you that they have primary amenorrhea, which means primary means from starting. So from starting, the female is not ovulating, no menstruation, and her puberty is also delayed, right? And she also complains of infertility. In this case, after removing the basic and the other factors, got the diagnosis of Kalman syndrome. Now, what you would be doing, the treatment is that hormone is not releasing, you would be providing it from outside. Easy, provide, and you would be providing in the form of pulsatile manner so that your LHFSS will be increasing, right? So basically, we give gonadotropin releasing hormone for other condition also, except for this. In case of a patient comes to you delayed puberty, okay. So in that also we give gonadotropin releasing hormone, but in a pulsatile manner, okay. And in hyperestrogenic conditions, we give gonadotropin hormone in continuous manner, right? It is, I told you, it is releasing in a pulsatile form. If we will provide it in a continuous matter, then your estrogen, progesterone, FSH, everything will go down, and your hyperestrogenic conditions will be get affected by these, like precocious puberty, endometriosis, fibrosis, okay, fibroids. Now you have hypogonadotropic hypogonadism condition. All right. Why it is called hypogonadotropic hypogonadism condition? Because gonadotropin hormone is not releasing, so hypogonadotropic hypogonadism, because other hormones are not also not there because of GNH, right? And this is what you have studied on your pharmacology, that we use SERM, which is an antagonist of estrogens. Clomiphene citrate we are giving for ovulation induction. Tamoxifen we are giving in case of breast cancer. Raloxifene we are giving for osteoporosis. Omelaxofene we are giving for centrocommon. We know that is an active ingredient for it, right? Now the main, you studied menstrual cycle, you understood all that. Now other things which you need to know for estrogen and progesterone, which will help you for your all the gynae questions, okay, and your concept will be clear. This is the basic thing, that there are four types of estrogens, 1 2 3 4 type, and their name is ester 1, estradiol, estriol, and ye. How you are going to remember is, ester 1 is 1 when you remain single, that is menopausal. Estradiol is when you are two, your male, your partner and you, so you are reproducing in that stage. So in reproduction age you have E2, and E3 is triol when you are pregnant and you're going to become 3, so pregnancy, right? Now for progesterone also you have four types of progesterones, right? Read them once, you will understood, guys. Now you need to know the where is estrogens coming from. I told you granulosa cell, right? Then your placenta also, and your progesterone, it is coming from your corpus luteum, somewhat from granulosa also, but major from corpus luteum, right? Now where it binds to, when a estrogen comes, it binds to your sex hormone binding globulin and free albumin. And progesterone also binds to albumin and cortical binding protein. Just read them every time so that it remains in your mind when you comes in your exam. Then the end product of both of these you must know. Now you, what main cheese, what you need to know is their effect on different organs. See, Estrogens, what it does on uterus, it helps in proliferation. And what progesterone do? They stop proliferation but increase secretory action, है ना? It support endometrium, it producing secretory. Now you have what, if you will get an endometrium biopsy, okay, and in your first half cycle where estrogen is a dominant hormone, so you will see this type of slide where you will see a simple glands, short and cystic tubular type glands in your uh, biopsy slide, okay. And when you will get a biopsy from ovulating period, so you will get a slide like this, and you will see glands which are begin to coil but they are not coiling yet, and subnuclear vacuole is present. That is the sign of ovulation on biopsy, could be asked in your exam, okay. And if you'll get a biopsy done on a second half of your cycle, then you would be seeing there will be coiled, very thick juicy glands, right? So these are called corkscrew appearance or sawtooth appearance, right? And the effect of estrogen and progesterone on your cervical mucus, when there is thin watery, which is stretchable on your fingers. You must have seen your images in PSM and gynae, that thin liquid which is very sticky, and you can stretch it between your fingers. That is spin bucket sign, you call it. That that fluid is called as a cervical mucus, which is produced in your first half your cycle before ovulation. So you can get an idea that you are in your proliferatory phase, right? And if the fluid which is coming out the vagina is thick or viscous or scanty, that it is not, it's not stretching between your finger, that is called tack. Okay, so you get an idea now the progesterones are high. Okay, and if you'll see that fluid on under microscope, you will see increased level of estrogens because firning will be there. And when progesterone will be there on slide, you see that fluid, no firning will be seen. Okay, so this firning present appeared by 8th day and disappears by 18th day. That is the one liner. Now when you will see endovaginal epithelium, when estrogens are high, you will see superficial cells. This is MCQ, guys. Superficial cells, first half of cycle they will be present. They will stain with pink color, eosinophilic, okay, and a pycnotic nucleus will be seen. And if you will get it done during ovulation, under no under influence of, sorry, not ovulation, but in menopausal female, okay. So you will see no hormone dependency. You will see parabasal or basal cells. They will be blue in color or basophilic. You can say a big nucleus will be there. And when you will get a slide of vaginal epithelium during progesterone, you will see intermediate cells that they will also be of blue color cells, but their nucleus will be larger than superficial cells. This is the difference. Okay, now this is a question MCQ. See, wherever I have written question in my notes, these are very important. Okay, sample for hormonal study should be taken from. This is a question that from where you should take sample for your hormonal studying of menstrual cycle. So the answer is from your lateral side of your upper third, okay. And the sample for cystological study should be taken from posterior wall of vagina, okay. That is your MCQ. Learn it by heart. And the function of estrogen and progesterone on your fallopian tube is it increases motility and decreases secretion, and progesterone, they decrease motility and increase secretion, okay. Now on your breast, ductal development occurs, and when your progesterones are dominating, the glandular development is occur, and that's why in some of the female patient they have pain before the menstruation cycle in their breast. That is because the ductal glandular development is occurring. That's why. Salt water retention, estrogen causes retention and progesterone causes excretion. And their action on lipid profile, you read it. Okay, now this is important, that ultrasound appearance of endometrium. See, when you will see a endometrium under endometrium ultrasound under proliferative phase, you will see a white line of uterus. And when you will see uterus during ovulation, you will see a trilamellar appearance or triple layer appearance. See this type. But if you're seeing it in your after ovulation, then you would be seeing a thick white endometrium with posterior enhancement. This is endometrium. This one white line is your endometrium because it hasn't proliferated properly yet. Ovulation is properly proliferated, ready for ovulation. That's why it is thick and trilamellar appearance. And secretory, because now it is it has becoming juicy and ready for the shedding. So thick endometrium with posterior enhancement, that is important. Okay, now see, the normal ratio of LH and FSH is 1:1, but in case of PCOS, the it reverses, that LH is more than FSH. Okay, because LH is present from starting only. See, you know that LH surge should be there in menstrual to occur ovulation, right? And the patient, those who are PCOS patients, they are mostly anovulating, right? Their cycles are anovulatory. So why it is so? Because the LH hormone, whose LH surge is required, that LH surge is present from starting only. No surge is occurring. That's why the ratio of LH is more than FSH. Okay. Now, best time for LH and FSH testing. If a patient comes to you with complaint of anovulation, acne, and you understood that this might be a case of PCOS, and on ultrasound also you got that necklace pattern appearance, or polycyst in the kidney, in the ovaries. So you ask the patient to get an LH FSH testing done of both these hormones. So when you would be advising that patient is after menstruation, day 2 or day 3. Okay. Synthetic LH and FH is called human menopausal gonadotropin. Okay, that's an MCQ. Now these three conditions, you must know the basic difference. Okay, I will be telling you, I'm sure you can remember this. What is the meaning of hirsutism? Virilization and hypertrichosis. See, hypertrichosis is the basic. Hyper means zyada, excessive, trichosis means hairs. So if a patient has excessive hair growth, that is non-sexual, means not in the pubes, not in the arms, but in the entire body, then it is a case of hypertrichosis. Okay, what is virilization? And what is hirsutism now? Hirsutism, when a patient has excessive hair growth at the, like a male, okay, a male pattern excessive hair growth in their sexual areas like beard, mustache, okay, arms, armpits, in their chest or their pubes. So this is a case of hirsutism, right? So, and there is a scoring which is used for hirsutism, that is called a Ferryman or Galway score. Now, what is virilization? When the entire spectrum changes in female, which is, see, when a female is exposed to excessive androgens, her entire spectrum, her entire body would be different. How? There will be excessive hair growth in the male patterns like hirsutism, right? Deepening of voice will be there, like men's. Their muscle mass will be increasing, their clitoris megaly will be there, breast atrophy will be there, and the score which is used for virilization is Prader score. Okay, now you understood the meaning. If entire body has excessive hair which is non-sexual, then it is a case of hypertrichosis. If a patient complains of excessive male pattern hair growth, mustache, and beard, then this is a case of hirsutism. But a female comes to you with complaints of her breast is not developing, she's having high muscle mass, or her voice is deep now, and also this hair pattern, then you can say this is a case of virilization. Okay, now few conditions which are very important, and I'm sure 100% going to come in our exam, is PCOD. Okay, PCOD is polycystic ovarian disease. It is also called Steen-Leventhal syndrome. right? Now, what is the pathology? Why it happens that your ovary has a theca cells? I told you granulosa and theca cells. Your theca cells were producing androgens, which are going to your granulosa cell, which are converting these androgens to estrogens, excessive estrogens, right? So when your ovary has theca cells and they're producing excessive androgens, not normal level but excessive androgens, and these androgens are converting into estrogens, excessive estrogens, that now the female is having hyperestrogenic condition, and the normal ratio of estrogen type 1 and 2 is 2 ratio 1 ratio 2, but in the case of PCOS patient has 2 ratio 1, which means the ester 1 and estradiol, their ratio is 2 ratio 1, which is reverse of the normal. Okay, because high estrogens are producing, which is ester 1. One thing, now estrogens are high and the LHS and FSH their ratio is also reverse, that now it is 1 ratio 2, as I told you, because the LH hormone is present from starting only, because excessive hydrogen estrogens are there and they are causing feedback to LH, and LH is forming. So when there are excessive estrogens, there will be excessive LH, and if LH hormone is present from starting only in entire cycle, throughout the cycle, so their ratio is also increased and no ovulation is occur. That's why anovulatory cycles. Okay, as I told you, the test should be done on second or third day for LH and FSH, right? As I told you that LH is present from starting, no LH surge, anovulation, and infertility. Patient complains of infertility, right? Now, what happens? These follicles are not rupturing. That's why ovulation is not occurring and infertility is there, and they're not rupturing, staying inside the ovary only, and follicles are forming inside the ovaries only, and they're becoming these cysts. And when you get an ultrasound done, you see this necklace pattern on your ultrasound, which is classical, right? And insulin resistance also occur in such cases, and in that acanthosis nigricans we see on the patient neck, and also some patient develops diabetes in future. Okay, for diagnostic criteria of PCOD, what we do is rotor stamp criteria. You must know this by heart, right? These are three things. Out of these three, two should be there to call it this patient has PCOS, right? The one is androgens. If there is excessive androgens, the patient will complain of excessive levels of hirsutism, right? And also that patient complains that she has ovulatory dysfunction, which means that her period is not regular, comes in after 1 to 2 months. Sometimes she has excessive bleeding, sometimes it takes 2 to 3 months to come for period. That's dysfunction. And if she provides you the ultrasound which shows that she has 12 follicles in the ovary, and that their size is more than 2 mm to 9 mm, or their volume is more than 10 cc, then you can say that this patient is of PCOS. And the diagnostic criteria we use is rotor stamp criteria. This is the question of June 2024 FMG exam, PYQ, right? So this is all about PCOS, which you must know. You need to understand. This is only they are going to ask, nothing much. Okay, now the basic management. If we talk about the management, see, patient developed insulin resistance. What you would be doing? You would be providing metformin, right? If patient complains of irregular cycles, patient we would be providing OCPs for the regulation. If patient complains of hirsutism also, then OCPs and also laser therapy we would recommend. If patient complains of infertility in case of PCOS patient, then the drug of choice is letrozole, that is a aromatase inhibitor. It will inhibit to make excessive androgens, and all this condition will get down, right? Now second drug of choice is clomiphene citrate, that is a SARM, which will cause ovulation. And second line we can give human menopausal gonadotrophic, okay, or laparoscopic ovarian drilling can also be done. And third is Gynaecology, as I told you, in a pulsatile manner. right? Now we have these two condition, metabolic X syndrome. Okay, some of you would know this and some of you don't. Then how you can remember is metabolic X syndrome, that if a patient is fat and she is diabetic, okay, if her fasting blood sugar is more, then she is having diabetes, she would be having hypertension, so her BP will be raised. If her BP is raised, which means her triglyceride level would be high and her HDL would be low, and she is obese, so which means mostly Indian females have abdominal obesity. So this is the basic. She has diabetes, she has hypertension, and she has she has obesity. So obesity, triglyceride high, LDL, HDL low, BP, and fasting sugar. This is metabolic X syndrome. If any three out of these is there, then you can call it a metabolic X syndrome. What is Harian syndrome? It is hyperandrogenism, insulin resistance, and acanthosis nigricans. In case of PCS, you can see Harian syndrome. Now, got it? This is all about your PCS. They will ask now, what is endometriosis? See, PCOS, endometriosis, fibroids, and your adenomyosis. These are the four topics. Out of these, 100% will come in your exam. Now, let's read endometriosis. What it is? It is also a hyperestrogenic condition. Okay, excessive estrogens are forming. One thing. Okay, see, whenever they frame a question, they will be framing in such way so that you get to your answer step by step. Like, the question would be like a nulliparous female, that she is nulliparous female, comes to you with complaint of pain during intercourse, okay, and excessive pain during menstruation. This type of question will come, and she is nulliparous. You will get an idea of endometriosis. Okay, the most common side of endometriosis is ovaries, then you have pouch of Douglas, then your urethral sacral ligament, then broad ligament, then fallopian tube at last. One thing. What is endometriosis? Basically, it is your endometrium inside myometrium, right? We have endometrium, myometrium. So, the endometrium, if it is present between the myometrium, sorry, not in endometrium, it is your endometrium outside the uterus, pardon. Okay, so if your endometrium is outside your uterus, so you will be having pain at that side also, right? And what is the theory for this is that Samson's theory of retrograde menstruation, that the patient, the Samson said that whenever a patient, uh, I mean, what would have happened, that the patient who has endometriosis must have, her endometrium has traveled from her uterus to an through her fallopian tubes, and deposited at these places, out of any of these or at all these. Okay, so it would have traveled retrogradely and deposited at those places. That's why this condition has occurred. That's the theory which is provided by him. Most common syndrome, if a patient has endometriosis, is dysmenorrhea, that she has secondary dysmenorrhea, that the pain persisted till her last day of menstruation. That's the goal. Okay, the triad which is mostly seen in the patients of endometriosis is, she complains of pain during menstruation, she complains of infertility, she complains of dyspareunia, means the pain during intercourse. Okay, now for the investigation of endometriosis, this is asked in your question, the investigation of choice for such condition. So you must know that it is laparoscopy. Okay, and under laparoscopy you will see a gunpowder appearance, powder burn appearance, right? So if the excessive ectopic endometrium is present over ovaries, you will see a chocolate cyst under laparoscopy. If it is present on peritoneum, then you will see powder gun appearance. You will see black blue cystic lesions or white scary lesions. All right. Now, medical management for endometriosis is, this is a mnemonic. Guys, please let depression go. So we will be giving progesterone, letrozole, danazole, gestational, and your gonadotropin releasing hormone. These medicines are used for hyperestrogenic conditions. Okay. Now, gold standard for endometriosis is HP for histopathological is CA125 levels. All right. Now the third condition is your adenomyosis. What is adenomyosis? Your endometrium inside myometrium. And what is endometriosis? Your uterus endometrium, your endometrium outside uterus. Okay, one line definition, easy. If your endometrium is present within the myometrium, then you will say adenomyosis, and the question will be framed in such way that a female patient of age 40 42 has come to you with complaint of lower abdominal pain. She is multiparous female, okay, and she complains of excessive menorrhagia from few months. So this type of question come whenever a multiparous or a female of 40 years of come complaints of pain in your lower abdomen, then you have to think for adenomyosis. And the investigation of choice for adenomyosis, the best is MRI. First is TVS, which is a transvaginal scan that will show you the wallpaper appearance, myometrial cyst, but the investigation of choice is MRI only. Okay, and under MRI you will see thickness of zone between endo and myometrium, and that zone is more than 12 in size, which is normal is 5 that you need to remember. Okay, and the symptoms which patient would be saying is menorrhagia, dysmenorrhea, these are basic, right? And per vaginum you will see Halban sign, which means that the tender uterus you will see. The best treatment of choice is hysterectomy, which I told you earlier in the starting also. In most of the cases in gynae, it is always best if the patient is multiparous, family is completed over 40. It is best to get a hysterectomy done. There leaves no, chance of any other pathology. This is all about adenomyosis. You need to remember for our MCI exam. Cool, guys. Move forward. Fibroids. Now, what is fibroid? This is the fourth condition in gynae, which is important, right? Now, fibroid means it is a yes, it is a single see, basically, what is fibroid is it is originating from a single myocyte, okay, and forming a fibroid. Okay. Now, the symptom which patient will present with simple, that is menorrhagia. Okay, menorrhagia. Now, why menorrhagia? See, if a fibroid is forming, it means that the surface area of uterus increased because of that fibroid, and if surface area is increased, then from there also menstruation will occur. So excessive bleeding there. Okay, and the origination is from single myocyte. This is important that smoking is protective in fibroids only. This is also a question that most common pelvic tumor is fibroid only, and this is a benign tumor, nothing to worry about it. Okay, now it is estrogen and progesterone dependent tumor. Okay, so if a patient has in early 40s or 40 above the age of 40s, then uh, after her menstruation this fibroid size will decrease for sure. But if in case it increases, then for sure we have to rule out or suspect any malignancies, right? Now the classification which is asked in exam recently, also in NEET PG also they asked, you need to learn. See, you have fibroids which is extrauterine and intrauterine, which means inside the uterine cavity or outside the uterine cavity. Now if we talk about inside the uterine cavity, you have intramural, submucous and subserous. Okay, intramural means inside the myometrium. Submucous means and between the endometrium and the cavity, and subserous is on the serosa level, serosa layer. Okay, now intramural is between the myometrium, and submucous we have three types: type 0, type 1, type 2. 0 means that the fibroid is completely inside uterine cavity only. Type 2 means that uh, there are two types for type 1 also, that is if it is more than 50%, let's say 60 or 70% in uterine cavity, but less than 30% in myometrium. Okay, and there is also other, if less than 50% is inside endometrium, less and other 15 myometrium. Type 2 is if more than 50% is in the myometrium. Okay, and other is less than in 50, less than in uterine cavity. Understood? This is the image. Type 0, that completely inside the uterine cavity only. Type 1, sorry, that more in uterine cavity and less in myometrium. And type 2 is more in myometrium, less in endometrium cavity. Easy. Now extrauterine, if we talk about, in extrauterine you have cervical and broad ligament fibroid. Now in fibroid, if fibroid is present over cervical, then if it is present anteriorly, then patient will having complain of urine urgency again and again. Okay, frequency, they will be urinating again and again. If it is present posteriorly, then the patient will have urine retention. Okay, now broad ligament fibroid, if we talk about pseudo and true. Okay, pseudo means that the fibroid is present medial to ureter. It is pedunculated or pseudocapsule will be formed. But the true fibroid of broad ligament is when it is lateral to ureter here. Okay, and non-pedunculated, non-pseudocapsule is formed. This is the basic classification of fibroid. Right, these are few questions which is important given by Sakshi ma'am. You must know. Most common fibroid in uterine cavity is intramural. ठीक है, submucosal then subserosal. To begin with, all fibroids are intramural. Because why they are beginning from intramural only? Because the originate of fibroids are myocyte, and myocytes are present in myometrium. That's why intramural. Okay, now max symptoms like abortion, infertility are seen when submucosal fibroid is there. Most common presentation asymptomatic. Most of the fibroids would be asymptomatic. Okay, if urinary symptoms are there, then we will think of cervical fluid fibroids, sorry. Okay, and most common symptoms patients says is menorrhagia, excessive bleeding. Most common fibroid cause uterine inversion is fundal. If a fibroid is present on the fundus of uterus, then most commonly it will cause uterine inversion. Now, most common fibroid which undergo torsion, common sense, the fibroid which is pedunculated, that will get torsion easily, right? So pedunculated subserous fibroid. Now, most common fibroid undergoes calcification is subserous fibroid again. Okay, and they will uh, give a form of womb stone or a popcorn calcification. Now, what is a wandering fibroid? It is a pedunculated subserous fibroid with no connection to uterus. That is a pedunculated. Okay, wandering fibroid. Now, this is a structure of fibroid. See, the fibroid is least vascular from the center, and from periphery it is vascular part. So, the vascular part will be having a calcification, and the central part is which degenerates, because the basic degeneration starts from center only. Okay, and it gives a whole appearance of a fibroid. Now, most common degeneration which occurs in fibroid are haline degeneration. Okay, and in some rare cases you can see malignancies also, which is 0.5%, and most common malignancies are submucous type. Okay, and when you will see a histopathology of a malignant fibroid, you will see a loose pseudocapsule, hole, and a mitosis present. Okay, now what is a red degeneration? Okay, this is most commonly occurs in postmenopausal patients, and secondly in most common in second trimesters. Okay, what happens? A aseptic, without infection, a aseptic thrombosis of venous occur, which supplies to fibroid. Okay, a thrombus will be formed. So the patient will present to you with abdominal pain, okay, and fever and high ESR, but there will be no sign of infection in that patient because it is a aseptic thrombosis. Okay, so in these cases we never do surgery. We always do is what? Conservative treatment. All right, and the surgical management is, if only a one fibroid is there, to remove it only, we call it a myomectomy, and when we removed a uterus plus fibroid, we call it a hysterectomy. All right, if a fibroid is asymptomatic, we do nothing. But when we do surgeries, if we do not know the nature of fibroid, it could be cancerous, it could be malignant. So if we do not know the nature of fibroid, it is best to do a surgery. If subserous fibroid is there, then it can go under torsion, so it is better to get a surgery done. Or in case of infertility and recurrent abortion, if a female has a fibroid and she complains of abortion, recurrent abortion every time, it is important to get a surgery done, right? So this is all about your fibroid, adenomyosis, your endometriosis and PCOS. It is very important, guys. See, very easy to read. Once you listen to this video, you will read again my notes. You would be able to answer your question, and next time when you would be reading, it will take hardly 15 minutes for you to read these notes. All right. Now, medical management for used in fibroid is to decrease blood loss. See, the patient which comes with complaint of excessive bleeding and she has fibroid, the patient will always come with excessive bleeding complaint only for fibroids main. So our goal would be to decrease the blood loss, and for that, what would we give? Progesterone to maintain the endometrium, right? So progesterones, OCPs, and tranexamic acid for the blood. Now, our goal is also to decrease the size of fibroids so that menorrhagia problem would be solved, right? So we would give estrogens and progesterones to balance out. Now, investigation of choice. Transvaginal scan, right? As I told you, hysterosalpingography will also be done, and that will show you a filling defect like this, as you can see. And when a hysterosalpingography is done, okay, the most common complication of this is perforation. What happens if a perforation occur at a fundal position? Then you have to do nothing, you have to observe only. But if the perforation is lateral or posterior, then you have to do immediate laparotomy. Okay. And for second most common complication of hysterosalpingography is fluid overload. If you report a fluid deficit, then the patient will have hyponatremia and patient can go under cerebral edema. This is what you need to remember. And also, you know that a figure classification is used for fibroids. Then this is the type 1 2, type 0 1 2. I told you, submucosal type, right? That completely in the uterine cavity, 50% in uterine, more than 50% in uterine cavity, and a little bit in myometrium. And if it is more than 50% in your myometrium and less than in endometrium, this is your 0 1 2. Then 3 4 you read intramural, then you read 5 6 7 and 8. Read it again. Okay, you're done with fibroids. There, try practice MCQs, you will understand, and I'm sure from next time onward you don't have to read it again and again. Now, menopausal. Okay, what is the meaning of menopause? Is that the cessation of periods for more than 12 months. Okay, that is when you will call a patient that she is a menopausal female, when her periods are cessation for 12 months. Okay, the common age is 51 years, but for Indians it has become 47 now. Okay, premature menopause and premature ovarian failure we call when the female stop menstruating under the less age of 40 years. Okay, now when we call it a delay menopause, when after the 55 years of age still the patient is menstruating and then the menopause has come. Okay, so in such cases it is always important to rule out any endometrium or ovarian cancers. Very important, right? Pathophysiology, what it is in menopausal female, what happened? Ovarian failure occur, low estrogen, low androgens, low testosterone, no hormones. Now what happens when estrogens get down? It is important for our bone mass. What happens? Your bone mass decreases when your estrogen levels go down, and osteoporosis occur in female. That's why in all the females who are in their menopausal age group, we provide all the vitamin D, calcium supplements, so that her bone stays healthy, and because they are very easily prone to get osteoporosis, right? Now she gets dryness of vagina, which is called senile vaginitis, and her FSH increases. So if to check to rule out the female is is in her menopause or not, then you will get her FSH LS level check and they will be increasing. Okay, sagging of skin will be there, and there is also increased chances of heart attack, right? When the female has osteoporosis, menopausal female, most common fracture is vertebral compression. This is also a question from your ortho, that most common fracture of patient with osteoporosis is vertebral compression fracture. Then you have Cooley fracture and the fracture of femur neck, number 3. But number 1 is vertebral compression. Okay. Now the levels of FSH. If the level of FSH is more than 40, it indicates menopause, right? The most important characteristics of menopausal female is hot flushes. She complains of vasomotor symptoms, right? Excessive sweating, heat, reddening of face. These are because of the withdrawal of estrogen levels. Okay, and one more thing, that LH and FSH is increased because of the low levels of estrogens, and they will be released in urine also. That is called human menopausal gonadotropin. Okay, the treatment for hot flushes is HR, human replacement therapy. If a female has an intact uterus, then we would be giving her estrogen plus progesterone pills. But if her hysterectomy has done, then we will provide only estrogens for the ovaries. Okay, we will also provide SSRI, serotonins, which is fluoxetine. Okay, in such cases. Now see, hormone replacement therapy. What is this? And we use it in menopause for hot flushes, first line of treatment for osteoporosis also, and for senile vaginitis we provide estrogen creams to the female patient. Now if female has osteoporosis also, then first line we would be giving a bisphosphonates. Okay, and the side effect of this bisphosphonate everyone knows, that is gastritis. Now this is important, that um the drugs and their side effects. That raloxifam gives side effect as hot flushes, danazol causes hirsutism, clomiphene citrate can cause multiple pregnancy or ovarian hyperstimulation syndrome, and human menopausal gonadotropin can also cause multiple pregnancy plus ovarian hyperstimulation syndrome. Okay, now your puberty. What is puberty? It is a sequence of puberty which is important, you must know in male and female. See ye na, you need to learn the this complete chart. How? See, puberty in female, you need to know the average age for a female is 10.5 years, and for male is 11.5. Okay, now first sign you will see in a female patient is growth spurt, and the visible sign we can see of puberty in female, which is visible, that is her thilarch, which is her breast budding will be there, the areola and the nipple. Okay, and then pubarch, which is your pubic hairs, then the menarche, which is your menstruation. This is the pattern of puberty in females from up to down. So you need to remember, in females from up to down, first thilarch, which is her breast budding, then pubis, puberch, then menses, which is menarche. This is the pattern. Okay, and sometimes they ask the most specific sign and most visible sign of puberty in female, that is thilarch. Okay, now if we talk about males, they are different, so you need to know their first thing would be their testicular enlargement, then their penile enlargement, then pubarch, then peak height velocity. So in males from down to up, and in females from up to down, that you need to remember. And then you can easily see first, if you see a female, her breast, then pubis, then you will see vaginal menstruation from there. This is the order. And if you talk about males and male child, then in male child you will see from down to up, you need to remember. So down, first of all, that from down you will see testes first, then penis, then after penis your pubis come, then pubis your height, peak height velocity. This is how you need to remember. Sometimes they ask this order also. Okay, so what is the best development means? If in any question it is written secondary sexual characteristics in female, which means the development of the breast. Secondary sexual characteristic means the development of the breast. Okay, so what happens when a female patient develops, her breast develops, which is her secondary sexual characteristic, her epiphyseal plates of bones are closed because of the estrogen hormones, and the height of the female patient stops. Okay, for pubic hair and axillary hair, you need androgens which are produced by your theca cells. Okay, now they have asked the staging, which staging we use for puberty of male and female. That is your tenor staging. All of you know, right? Now we have two conditions in puberty, that is your precocious puberty and your delayed puberty. If we talk about your precocious puberty, means early puberty, and delayed puberty means delay, right? This is the definition. If thilarch, which means her development of breast occurs at the age of 5, you will call that as precocious puberty. If the periods, which is your menstruation, start at the age of 10 only, you will call it a precocious puberty. Okay, the cause is unknown. Okay, and the treatment for this is best to give gonadotropin hormone continuously to downregulate the estrogens. Easy. But in case of delay puberty, if the absence of breast development and menstruation by the age of 13, normal is 10.5, by the age of 13, if still she is not menstruating, then you will call it a delayed puberty. Okay, so, or it is also called a constitutional puberty. So in that you will provide a pulsatile manner gonadotropin hormone. We already read about this, right? Now, pubertal menorrhagia, if a patient complains of excessive bleeding during her puberty time, so because initial few cycles are anovulatory, so they are irregular, they are painless, and excessive bleeding occurs in some female. So, per vaginal examination and dilatation and curettage in female patients are contraindicated, right? Okay, now let's talk about precocious puberty. So, female patient comes to you at the age of 10 of menstruation. You will say it is a precocious puberty. To rule out the cause, you will see a central and peripheral. There are two types of precocious puberty, which means that if a problem is present from the central part, which is your hypothalamus axis, hypothalamus puberty axis, that they are early stimulated, and that's why the hormone has increased, then you will call it a isosexual precocious puberty. Okay, and peripherally is from your ovaries. If from your ovaries because of any tumor, let's say for granulosa cell tumor, then you will also call it isosexual precocious puberty. Or because of androgen releasing tumor, it is called heterosexual precocious puberty. Okay, but if these excessive hormones are coming from adrenal gland, the condition we already talked about is congenital adrenal hyperplasia. Because of high androgens level, heterosexual precocious puberty will be called. This is the basic concept. Okay, you must understood. Now this is very important chart which I must share it with you guys. See, now you understand the puberty, right? Now what is primary amenorrhea? Amenorrhea means absent menstruation. Primary means from the starting. So if a patient comes to you with a primary amenorrhea, that she is not menstruating from starting only, now you will be having these 5 condition, guys. If any question related to primary amenorrhea comes to your exam, there will be only these 5 conditions you have to think of. They will give you clear cut idea of these. Let me tell you now. Female patient comes to you. Okay, she complains of that she says that her normal sexual characteristics are present. You also saw, which means her breast has developed. Okay, and she complains of cyclic pain, that every month she has pain in her abdomen but no menstruation occurs, periods nahi hote hain, no menstruation occurs, and on local examination you saw a bluish hymen. Okay, they can even show you the image of the bluish hymen, and on ultrasound you show that the uterus is also present, which means the uterus pathology is not there, menstruation is occurring but it is not coming out. Okay, now let's read this chart. This is the case scenario. So her breast is developed, which means her secondary sexual characteristic means estrogen is present. I told you, right? Uterus present hai, but it is bulky. Karyotype is done and it is 46XX, means female patient is there. Gonads ovaries is also there. Okay. Now other important points is they have given is bluish hymen. Okay. And which means if blood is present in the vagina, it is called hematocolpus, and if blood is present in uterus, it is called hematometra, right? So this type of case is called cryptomenorrhea or concealed menses or imperforated hymen. Okay, that everything in this female is normal. She's normally menstruating, her ovary is there, her karyotype is normal, uterus is normal, her breast secondary sexual characteristic is developed because there is no problems in the hormone. The only problem is that it is not coming out via hymen because her hymen is concealed or imperforated. That is the condition. So what the treatment of choice for this condition is cruciate incision on the hymen. So this is about this condition. If any question comes to you with blue hymen or a cyclic pain and all other things are normal, then always think of cryptomenorrhea in perforated hymen. Other anything else will not be the answer of this. Okay. Now next, young female comes to you, her 40, see they have given in the question only that young female complains of 46xx, her I mean her karyotype is 46xx with primary amenorrhea, means bleeding is not occurring, but her sexual secondary characteristics are normal, which means her breast is present, her estrogen hormones are there, but her absent uterus, the moment you read absent uterus means that her Mullerian agenesis has occurred because of Mullerian ducts. They are regress and not formed because of any reason. The patient does not have uterus, and if patient does not have uterus, there are no chance of menstruation, right? So her breast is normal, so estrogens are present which are producing from her ovaries, so her ovaries are normal. 46xx means female karyotype, right? But uterus is absent, which means uterus means Mullerian agenesis. So for this case, we will do a MAC indole vaginoplasty because only two-third of her lower part of vagina is present. So in this case, we will only do a vaginoplasty just to make just for the female patient, and will also give her hormones. All right. Third case, we have young female complaints of 46xy. Okay, karyotype 46xy. Primary amenorrhea, okay, no menstruation, breast is developed at stage 4, yani means hormones are present, estrogens. Axillary hair is of stage of 2 or 3, okay, and complaints of con- congenital inguinal hernia, that from birth she has a hernia in her inguinal region, and on ultrasound her uterus is not present. See, once uterus is not present, you will think of Mullerian agenesis, but inguinal hernia will give you the idea of what? Testicular feminizing syndrome. This is what you have to think, because 46xy karyotype is also given. If this karyotype was XS XX, then you could have thought for Mullerian agenesis, but 46xy, the moment you got this 46xy and congenital inguinal hernia, 100% that this was a male child, and her, because of excessive hormone, sh- the male child has become a female. Okay, the testis is inside the female, that is her inguinal hernia. All right. So in this case, her breast is normal, but uterus is absent because it is a male child. Wolffian duct would be there. Okay, that's why testes have formed. 46xy, a male karyotype. Inguinal hernia, ambiguous genitalia, because you cannot 100% say that whether it is a male or a female. So this is called a testicular feminizing syndrome or androgen sensitivity syndrome. So in this case, what would be the treatment? That now we would be removing these testes. Okay, so the testes will be removed. We will do a vaginoplasty for the female patient, and we will give her estrogen hormones, okay, for the to keep the breast developed. Okay. Number 4, a female patient again comes to you with amenorrhea. Okay, no bleeding, all right, and also complains of no sexual characteristics secondary, which means hormones are absent, and also but uterus is present. Okay, all right. So what will happen? Her secondary sexual characteristics are not there, so no hormone. There must be problem in the ovaries. One thing. Two, 46, when you get her karyotype done, 46 XO, the moment you see 45 XO, sorry, so you will get the idea of Turner syndrome. Let's say they have not provided the 46 XO, then what you would be thinking, streak ovaries, the word would be given, okay, or hypoplastic uterus. Then you will think of, again, because ovaries are streak, they are not producing estrogens, so secondary sexual characteristics are absent. Okay, then other few points they would be giving, like the patient is short stature, she has a webbing neck, shield chest, heart disease, all the symptoms of Turner syndrome they would be providing. So without thinking anything, you will think of Turner syndrome. And what is a Turner syndrome? Hypergonadotropic hypogonadism. Okay, hypogonadism matlab her ovaries are hypo, under they are not producing estrogens, but hypergonadotropics because of low level of estrogen. So high levels of LH and FSH will be there because follicle stimulating hormone are trying to produce more estrogen, and the negative feedback is getting, that's why these two are high. So Turner syndrome. For Turner syndrome, what we do is we give growth hormone, calcium, vitamin D, and estrogen progesterones to the female. Okay. Now, fifth and the last case that can come from this topic is female with primary amenorrhea. Again, complaints of no bleeding since starting. Her secondary sexual characteristics are absent. Okay, estrogens are not there. Ovaries problem could be there. Stature is normal, but her stature is completely normal. Her uterus is also present. Okay, and karyotype is 46XX. All right. So ovaries are normal, but hormone is not there. Uterus is normal. Her karyotype is normal. Everything is normal. Only her hormone is not there. Okay, which is estrogen. That's why her breast is not developed. So, and primary amenorrhea. So periphery, basically your periphery is okay. Now you have to think for the central. Central is your hypothalamus, right? So what you would be seeing, you will get her LHS, FHS done, and you will see low level of FSH and LH. And if they are low, estrogens are also low. That's why. And also patient will complain of anosmia. Then you will think of your Kalman syndrome, which means that the patient is having gene mutation of Calvin gene, that neuronal migration is not there. That's why since starting primary amenorrhea is there, from starting she's not having gonadotropin releasing hormone, and she's having this condition which is Kalman syndrome. What is it? It is a hypogonadotropic, means LHFSH is down. Hypogonadism means her estrogens are also down. All right, and for this condition, what would be doing? We will providing synthetic gonadotropin releasing hormone in a pulsatile manner so that her breast development will be there and menstruation can occur. Easy. These are the 5 conditions of primary amenorrhea. Among these, any of the topic can come in your exam, and that's it for this. Okay. These are few questions. The most common cause of primary amenorrhea, that is gonadal dysgenesis and Turner syndrome. Secondly, most common cause of primary amenorrhea is Mullerian agenesis. The female karyotype would be 46XX. The third most common cause of primary amenorrhea is testicular feminizing syndrome. Okay, that is 46XY. The best investigation for primary amenorrhea is always to get a karyotypic done. Okay, primary and secondary amenorrhea, these are the basic definitions. Now these are the charts for the basic understanding. If a patient comes to you with amenorrhea, there could be problem in ovaries, it could be Turner syndrome, okay, or craniopharyngioma, or her Kalman syndrome problem. Cool. And in secondary amenorrhea, again there will be problem at hypothalamus level. There could be stress. That's why some of the times when we females are stressed as at this stage, sometimes we have amenorrhea or we skip menstruation one or 2 months. Okay, it could be problem related to pituitary or pituitary gland, like prolactinoma or Sheehan syndrome. Secondary amenorrhea I'm talking about. Or at the level of ovaries can also be there, like PCOS, right, or premature menopausal. And at the level of uterus, like Asherman syndrome, right. Now, secondary amenorrhea, if we talk about, the most common cause of secondary amenorrhea is pregnancy, which is physiological, right? That's why for 9 months, no menses. Most common pathological, if we talk about, is PCOS, which is very common. Every third or fourth female has PCOS now. Okay. This is important that the intelligent quotient in Turner syndrome is normal, but in Klinefelter syndrome, it is decreased. Okay. Okay, now the last, which is secondary amenorrhea. Secondary amenorrhea means that the previously female was menstruating, but now from last 1 2 months, whatever is the period, she is not menstruating. So secondary amenorrhea. Okay, if a patient come to you with secondary amenorrhea, that bleeding earlier used to present but now not, you would be giving her progesterone, and if after giving progesterone patient start bleeding, then this was a case of PCOS, there were hormonal dysfunction. Okay. Now second case is scenario is if a patient comes with secondary amenorrhea with no bleeding after even giving estrogen progesterone, which is your OCPs, then you would be thinking of maybe Ashman syndrome. Why Ashman syndrome? As I told you, it is intrauterine adhesions between the in the uterine cavity because of thin endometrium. Most common cause of it is when excessive dilatation and curettage is done during postpartum hemorrhages. And what would patient complain of? Decreased bleeding or amenorrhea. And investigation of choice for this condition is always hysteroscopy. Okay. And the management is basically you will cut down the adhesions is hysteroscopic adhesiolysis. Okay. And you will also do a balloon catheter insertion to inflate the uterus, and also you will provide the estrogen progesterone hormones. The third one is if patient comes with secondary amenorrhea and she says that she is unable to lactate. Okay, then this could be a case of Sheehan syndrome. And what is it? When during the pregnancy your pituitary gland increases in size almost about 140%. So just after postpartum, the necrosis of anterior pituitary gland occur, due to which there is decrease pituitary failure occur and all the hormones decreases, and that's why prolactin hormones also decreases and the patient is unable to feed to the baby because of pituitary necrosis. That is your Sheehan syndrome. And one more case is if a patient come with secondary amenorrhea, that I'm not uh, menstruating, and also she complains of uh, sudden galactorrhea, and also complains of headache or visual disturbance. Any of the complaint, you will think of prolactinoma and you will ask that patient to get the prolactin levels done. All right. See, if prolactin levels are more than 50, then it is important to rule out prolactinoma, get an MRI done. Okay. And the treatment of choice, if prolactin levels are normal, then we will give cabergoline. If prolactin levels are high and causing infertility, then we will give bromocryptine. Okay, this is the management plan. Last words on secondary amenorrhea plus high LH and FH, then you will think for premature ovarian failure. All right, very high level, not high level. The best investigation is always a hormonal study. Okay. Now this is about a Sewer syndrome. It is also 46XY karyotyping. A patient will be having testes, mutation of SRY gene. So patient will have a non-functional testes because the Sertoli cells, they used to form anti-Mullerian hormone, and because of mutation of this gene, Sertoli cells didn't form anti-Mullerian hormone and the Mullerian agenesis did not occur. So female having will have a the patient will have a female internal organ because the karyotype is of male, but because of SRY gene mutation, Sertoli cells did not form anti-Mullerian hormone, so Mullerian agenesis did not occur, Wolffian duct promotion did not occur, so Wolffian duct undergo degeneration, and Mullerian agenesis did not happen, and Mullerian duct formed your internal female organ, which is your uterus, both fallopian tubes and lower one third of vagina. Okay, and then no testosterone was formed, so testosterone will form your dihydrotestosterone, and that dihydrotestosterone will not form external genitalia, right? So the external genitalia hasn't exposed to testosterone, so the patient will look at like a female child at the time of birth. Okay, and no seed, which is your seminal vesicles, epididymis, vas deferens, ejaculatory duct, all these will not be formed. So the patient karyotype would be of male, but the internal organs and external genitalia would be of a female child. Okay, so in this case, what we would be doing, we would be removing the gonads, vaginoplasty would be done, estrogen would be given for her breast development. Okay, so yeah, that's all for today's video. I am going to post another video from rest of the topics. I'm sure this would have helped because so many of you have asked for this. So yes, let's read it once, and from next time onwards, read yourself. And all the best to all of you guys. Last 1 month has left. Prepare very well for your exam. If you have any query or you want some notes, you want me to read some notes, anything, just ask me in the comment section below, and I would be very happy to help. And again, all the best to all of you. Stay focused and study. And if you like this video, like it, share it with your friends, and subscribe to my channel, and stay tuned for the further videos. Thank you so much.